So now I'll introduce CIPM staff. So when you hear your name, please introduce yourself, starting with Dr. McCall.
Hi, everyone. Julianne McCall, I'm the Director of Precision Medicine here in the Governor's Office of Planning and Research. I'm absolutely honored to see the distinguished panel that David has pulled together for this, this wonderful program. Happy to hand it over to my colleague next to me, Hannah.
Hi, my name is Hannah Butler-Struben. I am a fifth-year PhD student and the intern here, the policy intern here at OPR.
Saga, Ms. Barberis.
Hi, good morning or good afternoon. I'm Saga Barberis. I'm CIAPM's Intergovernmental Program Analyst.
And now to our CIPM colleagues on Zoom, Ms. Guan. Or is she still having connect?
Yeah.
She's having connectivity issues, ironically. So Dr. Spezzano.
Hello, I'm Teresa Spezzano. I am the Equity Officer for CIAPM. I can't wait to hear these proposals. It sounds amazing.
And Dr. Martinez.
Hi, my name is Ramon Martinez. I am CIAPM's recently onboarded Science Communications Officer. Looking forward to seeing all of the fantastic scientific research.
Thank you. So before I ask committee members to introduce themselves, I'd like to go over the protocol for today's virtual meeting. We have designed the processes to maximize contributions from all attendees. For the public attendees, we will monitor the Q&A function for questions and comments located in the middle of the menu bar. And if you need technical assistance during the meeting, you can send an email to ciapm@opr.ca.gov or call 916-323-9164. That's my phone number, which is my phone's right next to me. So if you have any issues, we will use Robert's Rules of Order for any decision making. And for discussion of public comment today, we ask that you use the raise hand function in Zoom and listen and say your name when we mute yourself in your organization. We'll get to a little bit more about that during that time. So I'd like to now call the roll for the committee members in alphabetical order by last name. So when I call your name, please briefly introduce yourself, state your name, title, affiliation, and area of expertise. So starting with our chair, Dr. Ajalori.
Good morning, everyone. I'm Dr. Olu Ajalori. I'm a professor of psychiatry at the University of Illinois in Chicago. And I do work in the intersection of computational neuroimaging and digital biomarkers to better track and treat mood and anxiety disorders. Thank you.
Dr. Bruno Anthony, I don't believe could join us today, so we'll move on to Dr. Baker.
Morning, everyone. Excuse me, I'm Justin Baker. I'm an associate professor of psychiatry at Harvard Medical School. I run a laboratory at McLean Hospital, where we use some similar methods to what Dr. Ajalori mentioned, computational psychiatry and digital methods, particularly pertaining to schizophrenia and bipolar disorder.
Dr. Barksdale.
Good morning. My name is Crystal Barksdale. I'm a program director at the National Institute on Minority Health and Health Disparities. I'm a clinical psychologist, and my area is in health disparities and structural intervention, structural and social interventions to reduce health disparities, and particularly structural racism and community health.
Dr. Fox.
Good morning. My name is Annie Fox. I'm an associate professor of healthcare data analytics at MGH Institute of Health Professions in Boston, Massachusetts. My area of expertise is mental health stigma and quantitative methods.
Dr. Gamble George.
Hi, I'm Joy-Anna Gamble George. I'm an associate research scientist at Yale University School of Public Health. My area of expertise is looking at gene-environment interactions and its effects on brain structure and function and how that relates to substance use, as well as other mental health concerns.
Dr. Hernandez Suarez.
Good morning. I'm Yogi Hernandez Suarez. I am Associate Professor of Obstetrics and Gynecology here at the Herbert Wertheim College of Medicine at FIU in Miami. I currently serve as the Dean of Students here. I have experience in implementing telehealth services under a value-based care model for folks with affective disorders.
Dr. Hudson.
Morning, everyone. My name is Daryl Hudson. I'm Associate Professor of Public Health at Washington University in St. Louis. I also direct our Center for the Study of Race, Ethnicity, and Equity. My work is at the intersection of social and psychiatric epidemiology and very interested in inequities across race, ethnicity, and socioeconomic status.
Dr. Carrig.
Morning, everyone. I'm Patricia Carrig. I'm a professor of clinical psychology at the University of Utah, and my research is focused on risk and protective factors for youth exposed to traumatic stress.
Dr. Lim.
Morning, everyone. Can you hear me?
Yes.
Okay, great. My name is Sana Lim. I'm an assistant professor at the NYU School of Medicine, section for health equity. I lead the mental health scientific track. I do multi-level behavioral interventions on mental health among racial, ethnic minorities and other multiply marginalized populations, such as sex workers and survivors of violence, using CVPR, intersectionality, and syndemic framing.
Dr. Nahas.
Good morning. My name is Ziad Nahas. I'm the Executive Vice Chair for the Department of Psychiatry at the University of Minnesota. And my primary focus of research over the last 25 years is treatment-resistant depression and neuromodulation.
Dr. Sanchez.
Good morning. I'm Catherine Sanchez. I am an embedded health services researcher with Baylor Scott and White Health System in Dallas, Texas. My focus is on health disparities and implementation science methods to address health disparities.
Dr. Saw.
Hi, my name is Annie Saw. I'm an associate professor in clinical and community psychology at DePaul University in Chicago. I study using community-based participatory methods, the intersections of health, mental health, and trauma for Asian American immigrant and refugee communities.
Dr. Shaban Nahad.
Hello, my name is Olash Shaban-Nijad. I'm an associate professor and director of population and precision health at the University of Tennessee Health Science Center, Oak Ridge National Lab Center for Biomedical Informatics. My domain of expertise is health AI, precision medicine, and precision public health. And I implement tools and algorithms and study different population, mostly populations suffering from health disparities, and implementing public health surveillance platform for multiple domains, including child mental health and adverse childhood experiences. Thank you.
Dr. Shortreed, I believe she's not on the call, but speak up if I'm wrong. I think she'll be joining us in about an hour. Dr. Trivedi.
Hi, I'm Luca Trivedi. I'm at UT Southwestern in Dallas. I am a professor of psychiatry, and I do research and translation research in depression and bipolar disorder using biomarkers for development and validation.
And lastly, Dr. Unutsu.
Yep. Good morning, Jürgen Onutzer. I chair the Department of Psychiatry at the University of Washington. In my research, I focus on clinical trials of innovative approaches to try to reach large populations of depressed individuals in primary care and other settings that have challenges with access to effective mental health care.
Thank you, everyone. So thank you for participating today. We have a quorum of committee members, and we have about 20 or so public members listening in on Zoom. So I want us all to bring us to the same page with a brief overview of CIAPM and the Depression RFP. Our CIAPM, or the California Initiative to Advance Precision Medicine, was established in 2015, and it is housed within the Governor's Office of Planning and Research. We award grants to support demonstration research projects that focus on reducing health disparities. To do this, we facilitate cross-sector partnerships with researchers, communities, healthcare providers, industry, and others. And we have a strong emphasis on community research collaborations to ensure research results are aligned with community priorities. We define precision medicine as the right treatment for the right person at the right time, and you can add on as many modifiers to that set statement as you would like, at the right location, under the right conditions, with the right cultural competency and linguistic competency, and so on. And so what we're here to talk about is our depression research program. We have $9 million in research funds to improve strategies for prevention, diagnosis, and treatment of depression. And we acknowledge and intend to fund mental health care for individuals. That's not a one-size-fits-all for the average patient. This funding will be for 3 to 5 demonstration projects at $1.8 to $3 million each. And the goal is to better understand and address depression in underserved communities. And a requirement is that nonprofit academic research institutions partner with community organizations. So to give you an overview of the request for proposals, here's a timeline. We released a notice of funding intent in January of 2023, and subsequently followed by the kind of the listening and community needs perspectives that Dr. Ramos mentioned. We had a request for information. We hosted listening sessions throughout the state last summer. And then we released the request for proposals in September of last year. This RFP was really informed by the listening sessions and RFI. The intent was to kind of ground the type of work and how the work is done that we intend to fund with community perspectives. There's a 3-stage process for responding to the RFP. First is letters of intent that were due in October of last year, concept proposals that were due in December. And we're here today to talk about narrowing down that concept proposal pool to invite a subset of those concept proposal applicants to submit a full proposal and announce awardees in March. The purpose of this RFP is to drive innovation in applying a precision medicine approach to understanding and addressing the prevention, diagnosis, and treatment of depression, particularly as a path towards reducing health disparities. In the aspect of precision medicine, we kind of intend to focus on is the individualization of prevention, diagnosis, measurement, and treatment, and really viewing patients as individuals and not just as patients or subjects, and these patients should be treated as such. We recognize that responses due to stress, environmental factors, and disease depend on many locations, including location, genetics, nutrition, fitness, age of exposure, microbiome, and other omics as well. This funding opportunity has certain collaboration requirements. First, authentic community partnerships from project conception to completion and beyond. In line with this, at least one PI or principal investigator must be from a nonprofit community-based organization, patient advocacy group, community clinic, or public or tribal entity that provides support to people with or at risk for depression. And by the full proposal stage, projects also must include at least one private sector collaborator who contributes in-kind financial or other resources to the project. This authentic community researcher partnership is based on and inspired by a National Academy's emphasis on the need for strong partnerships and collaboration to achieve a healthier and more equitable society. And we seek to encourage these high-quality collaborations. We provide guidance on our website as well as in the RFP. And we also have an asset inventory to facilitate collaborations, which is essentially an online mapping tool where you can see within California different researchers and community organizations, governmental organizations, kind of across the spectrum of the healthcare landscape about who is interested in precision medicine and really facilitate collaborations in that way. So in terms of this RFP, the timeline, as I was mentioning before, We are here on January 17th at the concept proposal selection meeting. Notification of finalists will be this month, hopefully shortly after this meeting. And full proposals will be due February 15th. Awardees will be announced in March, and we intend for projects to start in June for a duration of 3 years. Other parameters, like I mentioned, $9 million across 3 to 5 teams, 3-year projects, no more than 1 award per primary institution. Projects must be located in California, and self-funded out-of-state partners are allowed. Matching funds and in-kind contributions are highly encouraged, and funds may only be used for direct costs unless otherwise noted in the RFP or communication with us, written communication with us. So in terms of the numbers for this RFP, we received 60 letters of intent across 25 institutions. Of those, 41 submitted concept proposals across 22 institutions. We anticipate a finalist pool of about 10 to 15 applicants, and again, intend to fund 3 to 5 projects. We have a list of selection criteria that we laid out in the RFP, most of which is outlined on these next 2 slides. I'm not going to read these slides, but this is just to come to illustrate and emphasize our selection criteria, which is again is laid out in the RFP, as well as a portion of these selection criteria are in our enabling statute. All these criteria are listed in the RFP, which is you can see at the link here. So we have arrived at the portion for public comment. Before I do that, I just have a few things to say. Please note, public comment is intended for receiving general comments about this RFP, the content or process. It is not intended for elaborating on any particular proposals, but members of the public are free to make any comment they choose within the time constraints we have. After public comment, we will adjourn the open session and convene the closed session, which is open only to selection committee members and CIAPM staff. Until then, I would like to map out what the rest of the day will look like. We have a very full meeting ahead of us to ultimately determine which of the concept proposals will be invited to the full proposal stage. For many weeks, the committee has invested hours into careful review of each proposal, supplying a foundation that will form today's deliberation. The process we use is adapted from the National Institutes of Health. By the end of today's meeting, the selection committee will deliver its recommendations to OPR, consisting of a group of about 10 to 15 proposals. All project teams will be notified by email of the results of this process shortly, and will be provided individualized feedback. Most of the remainder of the meeting will take place in a closed session under the deliberation exemption allowed by our enabling statute. We are guided in this process by our enabling statute, which requires the convening of an expert selection committee to score proposals and recommend proposals to OPR. And we are very grateful to have convened such an illustrious panel from across the U.S. Each proposal was assigned to a diverse team of expert reviewers that brought a combination of disciplinary expertise, including expertise in depression and mental health, community engagement, health equity, and precision medicine. The role of selection committee members is to provide full, impartial, and independent consideration to the proposals they have been asked to review. Selection committee members have identified conflict of interest. Were not assigned to that particular review, and in today's meeting, they will be placed in the Zoom waiting room during deliberation and recuse themselves from voting on relevant proposals. Even if a member does not have an actual conflict, members may recuse themselves if they feel there's sufficient appearance of conflict. In addition, selection committee members and readers have also been asked to treat the review process as confidential until awards are granted. When the selection process concludes and final awards are announced by OPR in March, the selection committee members will be thanked for their service. In addition to confidentiality and conflict provisions, selection committee members for the duration of the RFP process must observe the requirements of the Bagley-Keene Open Meeting Act, which we will explain in the closed portion. CIAPM staff participation will be limited to supporting roles keeping time, addressing logistical questions, presenting proposal overviews, and making sure all committee members have a chance to speak. We'll also be here to answer any questions about the process, take notes on the meeting, and provide any support needed by the selection committee members during the process. So with that, we'll gladly receive public comment if there's interest. There are two options. I'm just going to stop sharing the screen so I can see a little bit better. There are two options for engaging. You may either present your comment yourself or write your comment in the Q&A for your staff to read out loud. To present, please use the raise hand function in Zoom. If you're calling in by phone, press *9 and listen for your name. When we call your name, we can unmute you and allow you to give public comment. So with that being said, are there any hands raised?
I would wait for 20 seconds.
Sure. We'll wait a little bit for public comment.
Just kidding.
We'll just give it. Okay. So we have a question in the Q&A. What are the review scoring parameters, significance, innovation, et cetera? Is there a particular emphasis on immediate utility, translation, implementation to healthcare? What we did is we took the selection criteria that are in the RFP that I mentioned, and we grouped them by the more or less traditional NIH categories: significance, innovation, and we broadened the innovation category to include potential for public benefit. So there's significance, innovation, or potential for public benefit, approach, project team, community engagement, and overall impact. Those are the 5 categories plus the overall impact that were the review scoring categories. And the second part is there a particular emphasis on media utility, translation, and implementation to healthcare. I would say that is included in the broadened innovation category with potential for public benefit. So any other public comments or questions? Great. So this concludes the public portion of today's meeting. The public open session is now adjourned, and we'll convene the closed session in a couple of minutes by, we have a few more, so we'll pause on that. We'll pause on the closing of the meeting and respond to the questions. So one question is, have you defined the next phase of reviews? So I'm not entirely sure what this question is getting at, but I'll just go over the process again. How will it work? I got you. So in terms of the next phase of reviews, this same selection committee will meet again in March. They'll be assigned proposals in a similar manner. They'll be assigned full proposals in a similar manner they were assigned concept proposals. A similar meeting will take place as this one in March. Again, the first portion will be public. We'll assign selection criteria, in a similar manner, and scores in a similar manner. And so essentially, it will be a similar process as the one today, except that the outcome of the meeting will be awardees and not finalists. I hope that answers your question. So the next question is, there was an emphasis on youth in the opening comments. Is this an adult RFP? So this is a RFP about depression across any domain. So youth, adults across any demographic, you know, yeah, I'll leave it at that. So I believe all the questions are answered. And so we will close the public portion of today's meeting once again. So the public portion is now adjourned, and we'll convene the closed session in a couple of minutes by 8:45. By 8:45 a.m. Pacific time. The closed portion of the meeting for the committee members is on a separate Zoom link that I included in my email last night. So thank you very much, and we'll see you in a few minutes.